Gentlemen, welcome to Day 2 of the NUS Initiative to Improve Health in Asia, Forum 2013. Economics, Technology, Assessment, and Health Policy Making. Our keynote lecture will be delivered by Professor Harvey Fineberg, President of the Institute of Medicine, USA. Professor Fineberg previously served Harvard University as Provost for 4 years and 13 years as Dean of the School of Public Health. He helped found and served as president of the Society for Medical Decision-Making and has been consultant to the World Health Organization. His research has included assessment of medical technology, evaluation of vaccines, and dissemination of medical innovations. At the Institute of Medicine, he has chaired and served on a number of panels dealing with health policy issues, ranging from AIDS to new medical technology. He's the author or co-author of numerous books and articles on subjects ranging from AIDS prevention to medical education. His keynote lecture is titled, Evidence and Medical Decision-Making, Lessons from the US and Implications for Asian Countries. I invite Professor Harvey Fineberg to deliver the keynote lecture.
Thank you very much, and good morning, ladies and gentlemen. It's a great pleasure for me to have this opportunity to speak with you and to share some reflections about health technology assessment, and potential lessons from experience in the United States as may apply in Asia. I want to begin by saying a few words about the circumstances of health in the United States to provide a context for this discussion. And I will also say a few words about the system of political and policymaking in the United States to be able to frame and understand current circumstances and attitudes about health and technology assessment. I'll then go on specifically to say a few words about the history of health technology assessment in the US and what essentially is an ambivalence about health technology assessment that I will explain. I'll say a few words about some examples of work that emanates from the Institute of Medicine that bears on the question of evaluation of technology and decision-making. And then I'll conclude by trying to draw some lessons from all of this experience that may be relevant to decision-making in Asian countries for your consideration. The United States today is in a remarkably paradoxical situation when it comes to health. We spend in the United States far more than any other country on health. Today, 1 out of every $5.50 that flows through the American economy is devoted to health care and health. That's nearly 18% of the total GDP, more than double of what we heard yesterday as a fraction of GDP is being spent in many other countries. At the same time, health performance in the United States, in comparison to other wealthy countries, particularly the 34 countries of the OECD, is mediocre. Life expectancy and many measures of health in the United States have been improving gradually over the last 20 years, but other countries have been improving even more rapidly. And so the relative standing of the United States in health performance has declined over these recent decades. It was just about a dozen years ago when life expectancy at birth here in Singapore began to inch ahead, where it has remained ahead of life expectancy at birth in the United States. So how is it that the U.S. finds itself in this curious situation in which it is lavishing enormous amounts of money on health and attaining mediocre results compared to others? It's a very serious and important question. And to understand it and its relationship to technology assessment, I have to say a few words of background about the US political system and the value system of the country. The United States was born in the era of colonial expansion of the 16th, 17th, and 18th centuries from Europe. Explorers and settlers came from a number of different countries. The first name for New York was actually New Amsterdam because of the Dutch settlements. The French settled particularly in the north and in parts of Canada, as we know even today, primarily remain French-speaking. The Spanish settled in parts of the south, but the predominant settlements and the dominant form of government came from the United Kingdom, from Great Britain. The United States grew out of a sense ultimately derived from the philosophies of the European Enlightenment and the decision taken by the people to form their own government founded on the principle of authority derived from the body of the public, from the people as a whole, with the notion of a democracy and voting. But beyond that core idea, and embedded in the very name United States, is the notion from the beginning that the nation was formed as a federation of then relatively sovereign separate states. New York, Pennsylvania, Virginia, Massachusetts, and so on. And the powers of the United States federal government from its origin derive from powers that are ceded to the federal government from the states, which in the tradition were the more sovereign power. Now, the powers that were ceded to the federal government, embedded in the United States Constitution, are very, very significant, providing for the common defense, the regulation of interstate commerce, the promotion of the overall well-being of the people, the ability to tax and to levy specific forms of taxation. All these powers were ceded to the central federal authority. In the United States Constitution, there are 10 provisions that are called the Bill of Rights, the first 10 amendments of the Constitution. Unlike most of the Constitution, which is about the powers of the authority of the federal and state governments and the elected offices, the Bill of Rights is about the protection of individual rights under the Constitution. What is significant for us in this discussion is that the rights that are enumerated in the Bill of Rights of the United States are all civil and political rights. They are the rights to free assembly, the rights to petition the government, the rights to the freedom of the press, the right to freedom of speech, the right to the free practice of religion. In fact, the Bill of Rights provides that the government shall not establish any state religion nor interfere with the right of the people to practice or not practice any religion they choose. Significantly for us, the U.S. Constitution is silent on social and economic rights. There is no constitutional guarantee of a right to a job. There is no constitutional guarantee of education. There is no constitutional guarantee of welfare or support in old age. There's no constitutional guarantee of a right to health. In the American tradition, all of these social and economic decisions are matters of choice, of the body politic. They are not intrinsic to the core constitutional rights of every individual. The United States was formed at a time with many compromises, the most significant having to do with the continuation of slavery in parts of the country at the very beginning of the country. This was not fully resolved until the bloodiest war for Americans in their history, which was the U.S. Civil War in the middle of the 19th century. The women's right to vote in the United States was not guaranteed until the passage of another amendment in the 20th century, the 22nd Amendment in 1922. And Social Security was not established as a pension fund until the 1930s. And the government's first major commitment to protection of health had to do with the protection of the right to insurance for the elderly and for the poor that were embedded in 1965 enactment of Medicare for the elderly and Medicaid as a system for the poor. Medicare was a federal program, and it was connected to the Social Security system of the United States. Medicaid was a partnership between the federal government and the individual states, and remains that to this day, so that the requirements and the provisions for the poor can vary to a degree from one state to another within the United States. Very importantly for our purposes, when Medicare was embedded in the Social Security system and the law was enacted, there was a provision of the law which said nothing in this law should be construed as affecting the practice of medicine in the United States. And the original concept, putting it into Social Security, meant that the purpose of the law was simply to pay the bills, because what Social Security did was generate checks. And so the idea was the doctors would submit their bills and the hospitals would submit their bills, and the Medicare program would pay. Now, this evolved very substantially over time, but it's very important to understand America's attitude toward technology assessment in the context of a government that does not guarantee a right to health and that establishes insurance schemes under the premise that they would not interfere with the practice of medicine. Now, at the same time, in the United States, health technology assessment was beginning in a very significant way a generation ago. The United States Congress in 1972 established an Office of Technology Assessment. This office was a branch for the Congress, a set of experts reporting to the Congress itself, overseen by a committee of the two parties and both houses of the Senate and the House of Representatives. The purpose of the Office of Technology Assessment was to provide guidance to the Congress about choices facing the Congress that had a strong technological component, such as energy and such as health and health care. Many of the principles that we now take for granted and defining purposes of health technology assessment had part of their roots in the work of the Office of Technology Assessment Health Unit that was led for a time by Professor David Banta, who's well known to many of you concerned with international health technology assessment, and other leaders such as Roger Herdman and Clyde Bainey, who were very, very important in setting the standards in the earliest days of the meaning of technology assessment, the methods of technology assessment, the purposes of technology assessment. But again, in the US context, this Office of Technology Assessment was exclusively authorized to conduct the analyses and then to present options to the Congress. The office did not make decisions of what was good or what was bad, and it did not even make formal recommendations of what was better and what was worse. Its mission, its assignment, was to lay out the options, describe the pros and the cons, and identify the choices for the Congress as clearly as possible. Now, this office did have a very substantial influence, nevertheless, because the analyses on technologies ranging from imaging to immunization were very thoughtfully carried out, engendering a large activity in the academic community of the United States, methodologies that were being developed and championed around cost-effectiveness analysis, cost-benefit analysis, decision sciences, systems analysis, and their applications to health, all developed in the US in tandem to the Office of Technology Assessment's work. That office was disbanded in 1995. It was disbanded in part because it was beginning to be seen by some in Congress as having a partisan cast or potentially favoring the philosophies and ideas of one party over another. At that time, there was no official body in the United States that was carrying out technology assessment even in an advisory way. And indeed, there has never been a health regulatory body at the federal level in the United States that has used officially analyses of cost as well as benefits in order to make decisions. The US Food and Drug Administration, which regulates the release of new drugs and the purity of the food supply in the United States, makes decisions based on benefit and risk analysis, not according to cost. And if the Food and Drug Administration refers to cost, they are referring to the costs of regulation and the impositions that are imposed by regulation on companies and others that are being regulated. So a decision by the US Food and Drug Administration has no direct bearing on the cost of the agent. That is left for other decision-making about coverage. The Centers for Medicare and Medicaid Services, which now oversee the government main programs of insurance, also are authorized to make decisions mainly on the basis of clinical need. Is it a standard of care? Is it appropriate? Now, resulting in this attitude about regulation, coupled with a predominant fee-for-service payment system, a very complicated administrative structure, you can begin to see why costs could accelerate and grow to such enormous proportions as they have in the United States. There have been certainly efforts in government agencies to look specifically at the quality of care and at outcomes of care. There is an agency for healthcare research and quality that does excellent work itself and that stimulates a lot of other work on evaluating care. But I can tell you, in the early 1990s, when the Agency for Healthcare Research and Quality released an assessment that criticized the use of early surgery for back pain, the office was nearly funded out of existence because of a backlash from the orthopedic surgeons who appealed to the Congress to stop this from going forward. And so America's ambivalence about technology assessment is rooted in part in its political past and in part in the vested interests that are embedded in the existing system of care and payment. Keep in mind, to understand the American preferences about technology and about the use of funding in healthcare, every dollar of expense to the government or to the people in healthcare is also a dollar of income to some actors within the healthcare system. And so there is tremendous source of vested interest in maintaining and strengthening the current system of payment. The Centers for Medicare and Medicaid Services that cover such a large number of people who are either elderly or poor, you might think are in an extremely powerful position to negotiate prices, for example, with drug companies, as some of our speakers yesterday explained, are negotiated and managed in different countries. But the Centers for Medicare and Medicaid Services has never negotiated prices with drug companies. And indeed, only now is there discussion about how and in what ways, under the new reforms, should that be carried forward. So, in the United States, when academics, analysts, and others talk about cost effectiveness or cost benefit or just cost, the people hear the word rationing. When we talk about limits, Professor Sanson talked about that yesterday, the people in the United States Congress hear rationing. And this is a very negative construct for the United States. A good colleague, someone known to many of you, Dr. Donald Berwick, was the acting administrator and then appointed in a recess appointment, meaning he was not approved by the Senate, but the president has the power to make such appointments for a period of up to 2 years under the Constitution. He was appointed as the director of the Centers for Medicare and Medicaid Services. He is a very eminent physician. He's devoted his career to patient-centered care, to improving the safety of care, the quality of care. And yet, he was never approved by the United States Senate. In part, it was argued that he had favorable views of the British National Health Service. So take that, David. Now, you might say, well, is that such a crime? Is that such a defect of character as to render one unqualified and unfit for service? Well, in the political system of the U.S., it's the prerogative of the Senate to approve, advise, and consent for such appointments. And in this case, the Senate did not approve the appointment, even though the majority of the United States Senate is actually a member of the same party as the president who appointed the individual. So you can see how sensitive these constructs are within the U.S. context. Now, let me move to a brief description of some examples of studies at the Institute of Medicine that bear very directly on this circumstance of technology assessment and evaluation of practices. I want to emphasize that the Institute of Medicine in the US model is an independent body of government. It is not a branch of government. It is not connected directly in any organizational way to the government. It is legally a separate entity as part of our national academies of sciences and engineering, and now the Institute of Medicine, which are chartered under a charter granted in the time of President Abraham Lincoln in the 1860s to be available to give advice to any agency of government on any matter of science or technology. And the Institute of Medicine, which began in 1970, is premised on the idea that it is responsible to give independent advice to improve health. And the advice may go to government, it may go to the professions, it may go to the public. And we also say that the mandate of the Institute embraces the health of people everywhere, because advice to the United States government may well have impact on the health of people in other parts of the world, as illustrated, for example, in the evaluation of the PEPFAR, so-called President's Emergency Plan for AIDS Relief, the largest global aid program of the United States government and directed specifically at the care and prevention of HIV in selected parts of the world. So the Institute of Medicine has this privileged position of independence, and it can be called upon, or it can initiate itself studies and activities. Sometimes the government is not ready to ask for something that you would think is obviously important. For example, end-of-life care in the United States. This became another political hot potato, meaning nobody wanted to hold it. During the debate over health reform in the last few years. The reason? One provision in the original proposal said that hospitals on patient admission should be required to have a conversation with the patient and the family about the patient's preferences in case they are in extremis, in case they are in very advanced stage and at risk of dying. Now, that provision was attacked by the opposition as introducing death panels in the United States. Now, death panels was a very dangerous sounding concept. It had nothing to do with the proposal, but it took on a life of its own on television, in the news media. I can tell you, my mother called me and asked me, are they really going to have death panels? It was everywhere. The administration, in response, said, strike that from the proposal. We're not going to talk about end of life. It's eliminated from the proposal. And not only that, but basically no officials in the government could talk about end-of-life care. They just couldn't talk about it because it would raise the specter of the death panels. In fact, when Dr. Berwick was the administrator of CMS, he introduced an administrative ruling that said, okay, you're not required to have this conversation, but if a hospital chooses to have this conversation, we at Medicare will pay for it. And that too had to be withdrawn because it again raised the specter of death panels. So the Institute of Medicine, I'm pleased to tell you, is now studying end of life and will report on end of life care next year. But no one in government could ask for it. The government did, however, ask for the first example that I want to cite that derives from the Affordable Care Act. This act, which was enacted a few years ago, is gradually coming into reality, and essentially it expands radically the insurance coverage in the United States. Not quite to universal coverage, but very much more widely covered than ever before. In that provision of the Affordable Care Act, preventive services are covered without charge to the patient. And the Secretary of Health and Human Services turned to the Institute of Medicine and said, what about essential preventive services, especially for women, that are perhaps not covered under the general preventive guidelines of the U.S. Preventive Service Task Force? What additional coverage should there be, if any? And so the Institute of Medicine assembled the committee, as it does in the usual way, eliminating as best we can any conflicts of interest, exposing and balancing previews or biases, and giving the committee license to analyze the literature and assess the problem and come forward with recommendations. And this committee laid out 3 criteria. They said they wanted to look for preventive services that affected large numbers of people. They wanted to look for services that had a potential substantial impact on health and well-being. And they wanted to be sure there was a sufficient quantity and quality of evidence to justify supporting the recommendation. And after they applied these filters and analyzed the situation, they came up with 8 additional specific services designed for women's preventive services, including, for example, screening for diabetes and gestation, and including the full range of FDA-approved contraceptive services. Now, you might think that's a rather benign addition. However, it has become the subject of a case now before the Supreme Court about the coverage. And why? Because religious authorities who oppose contraception objected to the requirement that employees of theirs would be covered and have access to contraceptive services. So the administration said, okay, if you are a church who opposes contraception, you're exempted from this. And by the way, if you are a church-related organization, such as a university or a hospital, you don't have to expressly provide the coverage, but your employees will have the coverage because the insurer is required to provide it, even though you don't directly pay for it. Even that is not enough of a concession, and the case will now come forward back to the court to decide, on the grounds going back to the U.S. Constitution, does this intrude on freedom of religion and the separation of the church and state in the United States? So it again comes back to a constitutional question. The very law of the Affordable Care Act was also challenged in the Supreme Court, and it was only upheld by a 5-4 vote. And the grounds on which it was upheld was not the grounds on which the administration had said they believed they were able to make the law. They said they were able to make the law because of the right to regulate interstate commerce. The Supreme Court said, well, not exactly, but because you penalize those who don't buy the insurance, and that penalty is administered by the Internal Revenue Service, even though you didn't call it a tax, it is a tax, and you have the right to apply that tax. So in the case of the essential health services, the Secretary of Health and Human Services immediately adopted the recommendations of the Institute of Medicine, but they are still playing out in this way in practice under the U.S. system. The second example that I want to cite of studies at the Institute really is a case of the early health technology assessment that we heard about yesterday from Lotte's presentation especially. And this is a study that is devoted to setting priorities for new vaccine development. It's an approach that is being taken under a new model of work for the Institute of Medicine. We've done previous studies of vaccine priorities for development. We did one in the 1990s. We did one about a decade ago, updating, looking at priorities for advanced countries and priorities for less developed countries. But in this study, we are trying to develop a flexible computational tool that will be web-based and widely available so that any decision maker will be able to apply their data, their values, in order to prioritize which vaccines would be most important for their populations at this time. We call that SMART vaccines, for Strategic Multi-Attribute Ranking Tool. So if the tool is as good as the acronym, it's bound to be a great contribution. A third study that I want to cite is a study that developed and promulgated clinical practice guidelines. That is to say, guidelines for the development of practice guidelines. How do we go about it? This is something that many authorities have deep experience with, but overall, today, more than 39 countries have promulgated more than 3,700 sets of guidelines. And the question that the committee was facing is, how should they recommend in the US that the approach to guideline development be carried out, particularly with concerns about composition and nature of evidence? And they came forward with 8 specific standards, recommending things that related to the participants, to the process, to the development and promulgation of results, to updating. And I commend this if you are interested. Every study of the Institute of Medicine is freely available as a PDF on the website of the Institute of Medicine. And this one, I think, may be especially relevant to some developing new models for technology assessment. A fourth study that I want to mention briefly is Learning What Works, an infrastructure for comparative effectiveness research. Because although the United States is leery about cost, increasingly it recognizes that it must pursue value, which in the US model means essentially the outcomes you achieve and the cost or the resources that you have to expend. So we can talk about value more successfully than we can talk about cost effectiveness, even though to measure value, you have to carry out an exercise that is essentially very similar. Very importantly, out of this work and advice came a new entity which is now getting organized under the law of the Affordable Care Act called the Patient-Centered Outcomes Research Institute. And that institute will obtain funding by a small tap on every insurance policy in the United States, public or private, in order to carry out comparative research of different technologies. And the committee also recommended that this work influence choices of coverage. Learning What Works is another specific study that I want to just mention very briefly. This study looked at, again, at ways of 16 topics, candidate topics that were ripe for comparative effectiveness research, and that was a contribution that lays out not just the specifics, but an example of how to go about setting these priorities. And the final study that I want to allude to is called Best Care at Lower Cost, which is the essential challenge to the U.S. health system. And this committee analyzed the expenses of the U.S. healthcare system. Believe it or not, the estimate is that approximately 30% of the U.S. expenditures on health do not directly contribute to the improvement of health. Now, to put that in dollar terms, that's $750 billion US per year that do not contribute to health. If I heard correctly, that would be more than double what China is currently spending altogether for health in China every year. So it's an enormous amount of retrievable resources. And the committee basically argued to establish a health system that was based on a model of continuous learning, premised on science, patient-clinician relationships, different incentives, and very importantly, a culture of learning and leadership in the health system. And I commend that also to your attention. In the final few minutes of my remarks, I want to point out 6 possible lessons that I believe may apply to others based on the U.S. experience. Obviously, it's not about replicating in a detailed or specific way the political or decision-making process of a separate country and culture. Each of us derives from our own histories and has to make decisions accordingly. But what is universal, I believe, in the first lesson is that to carry out health technology assessment, you must have the political support, both capital P political of leadership and small p political of the public, in order to be able to introduce and to carry out effectively health technology assessment. Second lesson, to do it, the experience of the IOM and others in the U.S. reinforce, as we heard yesterday, the value of independent bodies to render judgment insulated from political processes. I like to tell people that why I like my job at the Institute of Medicine is that I'm based in Washington and my only responsibility is to tell the truth. Now, others are supposed to be truthful, but that's my only job. After that, it's someone else's need. Third lesson, think about the entire life cycle of technology, not just about the moment of approval. The goal, after all, is not simply to allow useful or cost-effective technologies into practice, but it is to have the right technology applied at the right time to the right patient in the right way. And that requires a system of incentives, management, education, and culture that reinforces appropriate use at every stage in the life cycle. So it's a big challenge for assessment to carry through all the way to patient experience. Fourth lesson, every society has to think both about the demand side as well as the supply side of health technology. What are the incentives that lead people to use or not use technology in what ways? And these incentives, whether they emerge out of payment or other constraints, are crucial to determining whether you have a proper balance in the use of technology in practice. Fifth, every culture has to differentiate what aspects of health and health care it deems essential and a right from those aspects of health and health care that it chooses to regard as commodities that are available for purchase if the individual wishes, but are not part of the social compact of assurance about health. And this challenge relates to all of us. And finally, I think the lesson of building in continuous learning to our systems of care, which affects the adoption and use of technology, will be crucial to all of our success. As others have alluded, this is going to be able to take advantage of information technology in new ways, previously unavailable, but it needs to be a part of every health system that hopes to be able to be efficient as well as effective. So with that, I thank you very much for your attention, and I wish each and every one of you every success in coping with these very demanding and complicated challenges of health technology assessment. Thank you all very much.
Thank you very much, Harvey. Perhaps you would take a couple of questions.
Sure, if there's time.
Any questions from the audience?
Okay. Thank you very much. That was fantastic, and I really enjoyed the fact that you didn't use slides and that you started almost at the beginning. So I think that was really interesting. I wanted to ask you two things. The first is about the work you've done, the IOM has done on determining criteria for the essential health benefits package for the exchanges and where this work has gone. I think it's wonderful. And it must have been pretty challenging, again, given the environment in which you operate. The second is, I guess, I wonder what you think about the responsibility, or perhaps even the duty of those democratically elected by the majority of the population to educate and also to fight back against this type of misinformation and vested interest, instead of just backing down all the time and saying, oh, okay, we'll strike that one off then. Yeah.
Thank you for both questions. In addition to this work on essential preventive services, the Institute of Medicine also conducted a study on the criteria for determining essential services. We completed that report. It's now back in the hands of the ministry we call the Department of Health and Human Services, and we will see how that one plays out. So that's still in process in that sense. Your other point about understanding, public understanding, democracy, I was so struck. I think it was in the results that you showed us from Thailand about the public knowledge and the expert knowledge of different terminology, how lacking so many people were in appreciation, even recognition of the term, much less claiming understanding for so much of what we engaged in the fields take for granted. And I think there's a huge public challenge, a huge public education challenge. I think every society, it ultimately depends on the support and understanding of the public. And if we are going to succeed in making what are sometimes very hard choices and manage those in a way that is acceptable, we need to learn what is tolerable and acceptable, both in fact and in terminology, from the public, and we need to take up the responsibility of public education. I think it's not going to be accomplished without that, and I believe any of us who wants to succeed will need to bring the public along with us.
Anyone else? Any other questions? Can Congress defund IOM?
Can Congress defund IOM? Well, let me tell you just a very brief anecdote. We've done some things that offend people from time to time. For example, we did a series of studies on the safety of vaccines. The last one of those was on the safety of, the question of autism and vaccines, and particularly a preservative in vaccine used at that time, no longer being used, called thimerosal. It's a mercury-based preservative. And the committee scrutinized all the evidence. It assessed all of the quality of the various studies, and it came back with a recommendation that, an assessment first, that there was no basis in evidence to believe that the vaccines were related to autism. Now, one of the representatives in the United States Congress happened to have a grandson who developed autism, first symptoms appearing about a month after the child had received immunization, which happens with some regularity because the age of first symptom expression and the age of immunizations overlap. So this congressman called in his senior staff and he said, get me the budget of the Institute of Medicine, because he happened to be on the Appropriations Committee. When the answer came back in a half hour, there is no budget. That was for us a very good answer. So independence also means you have a certain struggle to obtain resources. We do obtain, in fact, 60% currently of our operating program budget from government agencies, but they are all contracted on a case-by-case basis. There's no general budgetary subvention to the Institute of Medicine in order to carry out its work. Could the Congress, in theory, prohibit any agency from working with the Institute? Certainly, it could. In fact, the current law protects the integrity of the National Academies and the Institute of Medicine in provisions that require that when an agency turns to the academies, they must not interfere in any way with the deliberations. So at the present, our relationship is good, but it does depend on the, let's say, the forbearance, at least, of the Congress to allow this kind of work to go forward. Please.
Okay, one final.
One more.
Thank you very much, Prof. Fineberg, for a very truthful and honest account of HTA in the States. In the context that, I just want to ask whether you could do some crystal ball gazing, in the context that the Affordable Health Care Act is actually going to be fully implemented soon, how do you see the AHA changing or molding health technology assessments in the States, and as well as using technology to increase efficiencies within the within the U.S. healthcare system, so that you can actually get a better bang for your buck?
Yeah. The Affordable Care Act, which is coming onto line, some parts actually in place, many more starting this and next year especially. The Affordable Care Act will have some effects directly on cost and expenses. In some ways, it will actually increase expenditures by broadening coverage. But other ways in the Act, particularly in the establishment of what are called accountable care organizations. These are systems of care where the providers accept global payment and responsibility for the coverage of all the needs of their population of patients. These alternatives to the fee-for-service tradition, I think, are very promising in terms of improving the efficiency and the use of resources, on top of the lessons that will be learned from the research of the Patient-Centered Outcomes Research Institute, and a number of other quality-based payment mechanisms which are also incorporated in the Act. So there'll be some pressure for increased cost, but also provisions that will, over time, with any luck, improve the efficiency and performance. Thank you.
Thank you very much.
Thank you all.